Okay, so we'll start with the week 2 assignment. So my name is Surendra Maharjan from Indiana University School of Medicine. So uh, I see we have 7 responses for week 2 assignment. Yeah, some people haven't done yet, so just feel free to fill it up. So I'll just quickly walk you through the questionnaire that we have. So question 1 was, why is synchronizing the MRI scan with the cardiac cycle important during cardiac imaging? So most of the people, you got it right, to capture the images at specific cardiac phase. So we don't do to capture images of lungs to reduce scan time or to access liver function. Yeah, we need to capture image at specific cardiac phase. Uh, why we need that? Because the cardiac is always in motion, and you can see the whole cardiac, the whole heart is covered by the moving organs, the lungs, the diaphragm, the liver, and the blood vessels. Everything is moving. So we need to reduce the motion artifacts there, and that we can improve the image quality, and we can access some cardiac function like ventricular ejection rate or some myocardial effusion, and also to evaluate the blood perfusion and blood flow. So if you want to do contrast agents study, then we can do that. And for the quantitative analysis, like some kind of strain function like myocardial strain or some wall motion abnormalities as well. Question 2. Which technique is used to minimize artifacts caused by respiratory motion during cardiac MRI? So it's respiratory gating. Yeah. So we can use respiratory gating by using some motion sensitive devices or some respiratory pillows. So we can use the gating window, that is especially during the expiratory phase where there is no motion or very less motion. So we can acquire images at that time, and then we can also acquire multiple images over several expiratory cycles so that we can average them together to improve the SNR. So we can improve the SNR like that. Oh, yeah. So question 3 was, native T1 mapping is used in cardiac MRI to measure. So it's tissue relaxation time. So native T1 mapping measures the intrinsic or the baseline T1 relaxation time of myocardial tissue, and it's also used to characterize the myocardial tissue and also to detect some myocardial fibrosis, monitor the disease progression, and differentiating the myocardial pathologies and treatment plan. Yeah, please feel free to ask a question when you want. So, which MR technique provides information about tissue iron content or edema in cardiac imaging? So it's T2 or T2 star mapping. So it measures the T2 star relaxation time and assesses the tissue iron content in the myocardium, such as hemochromatosis or sickle cell disease. So it's shorter shorter T2 star values indicates the disease. So T2 mapping assesses the tissue edema, and that's the accumulation of fluids, and longer T2 values is the edema compared to the normal. And question 5, extracellular volume fraction measurement in cardiac MRI is often used to assess. So yeah, it's fibrosis and tissue remodeling. So what's actually ECV? It's the assesses the proportion of extracellular space within the myocardium, that is the heart. So uh, it's used to measure the myocardial fibrosis, that is the excessive accumulation of collagen and extracellular matrix in the heart muscles. So they are fibrotic tissue are deposited in the extracellular space, so it's very sensitive there. And it's also used for tissue characterization, treatment monitoring, and the risk stratification, like how much risk there is for the heart. What is considered a normal range for left ventricular ejection fraction in cardiac MRI? So it's 55 to 70%. So how much the blood is ejected from the ventricle? That is the left ventricle. So if it's below 50%, it is reduced, and it's below 35, it's severely reduced. That means there's some abnormality. And in cardiac MRI, what is considered a normal range for T1 relaxation time of myocardium? It's 600 to 700. So in 1.5 Tesla, it's 900 to 1100, and in 3 Tesla, it's 100 to 100 milliseconds. So it's a little lesser in the question, but yeah, that's the maximum value.
Hello.
Yeah,
Hi. But can you go back a little? Then the question for this, yeah, the question itself, not the answer. The question itself. Yes, but the values we have, see, the answer is around 900,
yeah,
but the answer is given is way below it.
yeah. The thing is, it depends on the vendor and the specific patient. So the question here is the maximum value is 600 to 700, but if we check the literatures, you can see these values as well. So I just kept these values here. But
Okay.
for this question, 600 to 700 is the maximum value. So this is the
So,
correct answer.
is vendor dependent and patient dependent.
Yeah.
Okay. Okay. Thank you.
Okay. So it depends on multiple factors actually. It depends on the specific subject as well and the specific vendor of MR.
Thank you.
Which cardiac MRI sequence is known for its high SNR and excellent tissue contrast due to its balanced steady state behavior is SSFP. So its full form is steady state free precession. So what's steady state free precession is the steady state of magnetization in the tissue with sufficiently long T2 interval by keeping the TR shorter than T2. So what actually happens is when we keep the TR very shorter than T2, the longitudinal magnetization like this, it doesn't slip. Or even if it slips, like it's precession in the steady state like this. So there won't be change. So that's called steady state precession. And we can also do it in balanced way or in unbalanced way. Balanced way means we are using refocusing pulses to gather the contrast, signal contrast, or we can also use spoiling so that we can only generate this T2 weighted contrast or this T1 weighted contrast. But most of the time, we generate the balanced SSFP. And it's very essential. I mean, it's very important because it generates T2 by T1 stark contrast, which is quite good and quite sensitive for cardiac MRI since its contrast is very good for minor details in cardiac MRI where the tissues and where the muscle and the tissue are like similar. So with Smalley and SS Smalley, it's used to measure the T1 relaxation time. Yeah, that's correct. So it's the modified look locker inversion recovery, and SS Smalley is shortened modified look locker inversion recovery. So it's basically the inversion recovery sequence, just like the flare, which we use in uh, MRI brain. But this is little advanced sequence, as you can see. So it's used for T1 mapping, and it involves acquiring a series of images using series of inversion pulses. Like we can use 2 inversion or 3 inversion, but most of the times they use 2 inversion and they acquire like 3 or 5 images. So that way we are generating good contrast. So that's pretty good for Molly. And shorten Molly means we decrease the contrast, decrease the time period, I mean. So what is the main advantage of using T1 mapping techniques like Molly and SS Molly in cardiac MRI? So they allow assessment of myocardial fibrosis and edema because we use double inversion recovery pulse sequence, which is the black blood imaging that is the standard for cardiac MRI. But since this is more advanced than black blood contrast imaging, this gives more sensitive to myocardial fibrosis and edema. So it reduces the scan time, the Molly and SS Molly. It improves motion robustness. We will have less contrast, less motion, and we are using multiple T1 maps that is in a single scan. That is, we can acquire multiple images at different inversion times, like some inversion may be a little shorter and some maybe a little greater. And we are just averaging based on the inversion time. So that's again within a single braid hole, which is pretty good. And the advantage of shortened Molly is it takes less time, like 9 heartbeats, and for Molly it may take like 16, 17 heartbeats. So again, we have high quality images. Yeah. So this is a basic graph for Molly. As you can see, for first inversion recovery, they are taking like 5 images, and they wait for 3 bits for recovery, and they use another inversion pulse, and they acquire 3. So they sort out images, then they fit into the model, and they calculate the quantitative values. So this is shortened Molly, and there's the longitudinal magnetization. As you can see, it's shortened, so the recovery is faster here. So this sequence is the same. As you can see, there are 5 images, and here they acquire 1 image. So the only thing is they do now conditional curve fitting. So and this is faster since like there because this is recovery is faster, so it takes less time. Yeah, thank you. If you have questions, yeah, please feel free to ask me.
Okay, thank you very much, Mr. Suri. I think we should combine the whole question at a go. You understand? So that we don't take too much of a time.
Yeah.
So when I'm done with mine in the next 20 minutes, anybody that has question can just put it together. It's a tutorial. It's not necessarily a lecture. We are both sharing knowledge about what they have read during the week and all those. Okay, thank you. Once again, we apologize to everybody for the time we are starting. These are just technical glitches that happens once in a while. Once again, apologies on behalf of the organizers. We say very big apologies. We know your time is very important to you. Thank you, Mr. Sorin. Mr. Sorin just took time to go over the assignment that we submitted within the week. My own duty today is not on physics, but actual image acquisition. And then I will Mr. Sorin, can you disable your screen, or you grant me the opportunity to share my screen?
Okay, now you can share.
Okay, good. Okay, so can we see my screen?
Yes.
Yes, we can.
Okay, so basically I am not here to, you know, talk about physics. I'm just here to discuss just some step-by-step method in acquiring image during cardiac MRI. And then I'm caught in between trying to pass this knowledge to those who have been practicing cardiac MRI and to those who have never even started practicing MRI cardiac at the moment. So I don't know, I'm going to manage myself to make it as simple as possible. But either way, if you have been practicing MRI for a while, which I believe you have been doing, some of the basic things I'll be saying shouldn't sound so foreign to you. You should be able to get one or two ideas with what I'm saying. Good. So I'll be speaking based on this table of contents. I'll be introducing us to cardiac MRI, the preparation of patients. And you also understand that cardiac MRI has to do with some connection with the ECG cables. Different vendors have their various ECG cables. And then thanks to Mr. Surin, who has helped me to define BSSFP, and then the sign images, the perfusion images, and then the oxygenation MRI. And then we talk about some of the basic acquisition you're going to see during your day-to-day scanning, and then try to highlight one or two importance of the TI scout. I know we had a little bit of issue on this last week. And then the early gadolinium enhancement and the late gadolinium enhancement, and so on and so forth. Now, we cannot underrate the importance of cardiac MRI in our day-to-day practice, especially for global ventricular assessments. If you are doing cardiac MRI on a day-to-day basis, you realize that cardiologists and radiologists, they tend to want to know much about the left ventricle. And you'll be like, okay, what is going on? Why are they not also paying concentration to the right ventricle? We all know the importance of the left ventricle in the system, in the systemic flow, in terms of, you know, distribution of oxygenated blood all over the body. And then if there is any issue with the left ventricle, most especially, you tend to have secondary issues to almost every organ in the body. So cardiac MRI has really done a lot over the years, playing a big role in the effective characterization of tissues in the left ventricle, right ventricle, the atrium, even the aorta, and then also even at large the chest region. Okay. So one of the things that you have to know when you are taking on cardiac MRI on a day-to-day basis is the role the patient preparation has to play. You cannot underrate the explaining the procedure to the patient from one step to the other, most especially when it has to do with the breathing sequence, because you have to sit this patient down before the investigation, explain to them the importance of holding their breath during the scan. You also, some hospitals I know, they send their patient the consent form ahead of time. Patient reads through the consent form at home and send it back to them before the patient comes to the hospital the next day or on the day of their investigation. Either way, either you are sending the consent form to the patient on the day of investigation or before they come to the hospital, you are still correct. We all know the role patient changing gown has to play. I won't talk much on that. And then taking your time to carefully explain the procedure to the patient and telling them how long it is going to take. And then there's one thing we need to know, especially in LMICs, low and middle income countries. We use one stone to kill two birds. And when I say one stone to kill two birds, I mean we use you know, one sequence in MRI cardiac to kill different indications. Say, for instance, left ventricular hypertrophy and myxoma. We plan our sequence the same way, but when you come to the West, you realize that they plan sequences based on clinical indication. So for instance, if you have myxoma, you should be able to know the sequence you should be using to run myxoma. If you have amyloidosis, you should be able to know the sequence you are going to be using to run amyloidosis. And if you have a patient with a pericardiac effusion or something of that nature, you should be able to know the sequence you're going to be using to run that. And then for the patient positioning in cardiac MRI, is basically the same way you position for, say, MRI of the chest or MRI of the abdomen. Patient is in the supine position, either the feet in or the head in first. Whichever way you want to go by, you are free to go by. If your system allows you to do either the feet in first, fine and good. If your system allows you to do the head in first, fine and good. But either way, I've noticed that almost all your system, they run MRI cardiac based on the supine, the supine protocol. And then there's also that part of shaving the chest of the patient. You know, most of these patients, especially the male counterpart, they have this hair on their chest. And then if you go ahead and connect the ECG electrode on the chest that way, you might be getting reduced signal. So what you do is you try as much as possible to shave some, not all the chest, but some part of the chest, you know, where you are going to be placing the lead. Remove the hair after shaving, clean it up with gel, and then you wait for the gel to dry up a little bit before you connect your electrode, and then you connect your ECG. Okay, apart from the normal ECG, we know during MRI cardiac, there's also what they call the peripheral ECG, the one you connect to the patient, either thumb or the index finger. That's the peripheral ECG helps you to do 1 or 2 free breathing sequence. I know most of the 1.5 Tesla MRI we have in circulation doesn't really come with the peripheral ECG, but those of you who have modified system, and I know most of the vendors also, if you tell them you want the peripheral ECG so that you could attend to patients that have cardiac arrhythmia, for instance, they could adjust the system for you and then allow you to, you know, be able to use your peripheral gating. Now, one of the good difference between the peripheral gating and the normal vector gating, like you can see on the screen, is patients that have inordinate heart rates, whereby, you know, the heart rate is just going up, coming down, and then distorting images for you. You could just switch over to your peripheral ECG. That gives you opportunity to run some of these sequences on, you know, free breathing, and then you can do what you want to do. Don't bother about the connection of the ECG on the patient's body. When they supply your machines to you, maybe the GMRI, the Siemens, the Philips, and so on and so forth, it comes with manual, and then they will be able to tell you that this is the way we connect our own. What you can see on the system here is basically for Philips and basically for GE. Okay. Like I said earlier on, SWiM has done a lot of help to me by defining the BSSFP, which is the basic sequences we use for basic imaging in cardiac MRI. And then for the sign images is all about just, you know, it gets bulk of images together at different cardiac cycles. And then you could play these images in form of movies. Then you can see the diastolic phase, and then you can see the systolic phase. Okay. Of all these things I have listed here, you could go to the last one, which is the oxygen sensitive CMR, which is one of the things you are going to be learning during this training. We are all aware of the perfusion MRI that has to do with blood flow within the myocardium, or, you know, the heart tissue. And then you can use, depending on the indication you are working with, the radiologist can work out, you know, analysis of the blood flow within tissues. The new recent MRIs they do now that doesn't really give you much headache and doesn't really require you injecting the patient with contrast is the oxygen sensitive contrast cardiac MRI, whereby you analyze the oxygen content within tissues, within the myocardium. And then you are able to know the areas which are not really perfused with oxygen, and then you can rule out indications like fibrosis and then amyloidosis. And then under the oxygen sensitive cardiac MRI is also when we have the hyperventilation sequence, free breathing sequence, I'm going to play 1 or 2 videos during this highlight for us, just to show us the importance of oxygen sensitive cardiac MRI. So that most centers that are having issues with contrast imaging might just, oh, this really works well for me. I could just switch from perfusion imaging to oxygen sensitive imaging. Okay, yeah, steps to acquisition of image. Don't worry, I'm going to show you 1 or 2 images. Most of you that are just thinking, oh, is it going to be showing us words alone? Don't worry, I'm going to be showing you 1 or 2 images, but either way, there are steps to acquisition of images during cardiac MRI. I have tried as much as possible to list the steps here. If you follow these steps here, I think you don't really need to have much issues, especially for those of us who have never done cardiac MRI before. We could just follow this step. On a norm, you get your localizers that give you images in trim plane, axial, coronal, and sagittal. And then you get the axial images of the whole chest this time around, so that the radiologist can just have an overview of what is happening in the chest region, apart from just limiting yourself to the heart. And then under cardiac MRI, there are some basic sequences or basic projection, like we call it in X-rays, that you cannot run away from, because they are going to form a basis for your MOLY and SH MOLY that Surendra talked about. They are going to form a basis for your hyperventilation sequence. They are going to form basis for your late gadolinium enhancement. And some of these basic sequences are the 2 chambers. It's just like you say the AP and lateral in X-ray, you understand? And then you have the modified views. For cardiac MRI, you cannot run away from your 2 chambers. The 2 chambers basically displace the left ventricle and the left atrium. You also have the short axis. You also have the 4 chambers. And when you have done this 2, 3, 4 chambers, you can then think of going in advanced format, depending on what your cardiologist might want. You might also want to include for them the left ventricular function or left ventricular outflow tract. You might also want to do the aortic valve for them. You might also want to do the full length of the whole aorta for them. These are very simple sequences that you can close your eyes and then run up for the hospital and get your stuff going. So you run the localizers, you do the axial. The dark blood practically helps us to reduce signals from blood, so that we could see the cardiac tissues very well and blood vessels. So we could, basically plan our 2 chambers, our short axis, and then the 4 chambers very well. Now, if you have done this localizer, it is this localizer you then use to plan the same 2 chamber, 4 chamber, short axis, and 3 chamber of the sign. Like I said earlier on, the sign is just a compact of images, piling up images in diastolic and systolic function, and then you can scroll through them to know what exactly is going on in the heart. Okay, just take note of this, because I'll be taking them. So from here, if you look at my screen here, the localizer, that will take me to the first localizer, which I told you is going to be giving you image in 3 plane, the 3 axial, sagittal, and coronal. Just a single, but it doesn't really take time, just less than 4 minutes. And the good thing about cardiac imaging is that it doesn't really take time. Most of the sequences are maybe 4 seconds, 5 seconds, 6 seconds, 11 seconds. And then you should be able to tell the patient to, hold their breath during this period. I'd like to state something to us here, and that is, if you look at these images that I posted on this screen, you see this green box that comes this way. Can we hear me? Sorry, I think I'm just going. Can we hear me?
Yeah, we can hear you.
Okay, good, fine.
Yes, sir, we can.
Let it not look like I am just going and not getting to interact with my participants. Okay, good. Look at these images I posted. Good, thank you. Look at these images I posted here. You can see this green box. There's something they call shimming in cardiac MRI. Now, because the heart is constantly in motion, and generally motion in radiography tends to cause blurring to the image. It also applies to MRI cardiac. When you are scanning a patient and then you you should be able to, two things I need to state here before I go forward. I'm looking at my time, don't worry. Is one, when you go to some centers, when they are giving the patient breathing instruction, you will hear breathe in, breathe out, breathe in and hold your breath. When you ask the patient to breathe in and hold their breath in inspiration, you can scan. Or some centers, you go, they will tell the patient breathe in, breathe out, and hold your breath. That means you are scanning in expiration. The first one, you are scanning in expiration. The second one, you are scanning in expiration. I did some diggings under the SCMR, that the Society for Cardiac MRI, which are one of the major institutions vested with the practice of cardiac MRI. The standard is that images should be gotten in end systolic, that is during expiration, because you get to know the true shape of the heart, and then the patient could actually hold their breath at that time. Now, what this also means is when you ask the patient, breathe in, breathe out, hold your breath. If you do this, the patient could hold their breath at that point. They are very responsive to holding their breath during his expiration. But when you ask them that breathe in, breathe out, breathe in and hold your breath, there's every tendency that the patient could take a little bit of drop in breath. And when there's a drop in breath, you are calculating maybe pre and post contrast for the radiology, there might be that little difference in figures you are getting. But either way, that's for one. Then number two, look at this green stuff. Shimming is very important. Every system comes, you should just learn how to locate shimming on your system. For GE, for Siemens, there's a section of the MRI that they write help. You could just type shimming in that help. That shimming will tell you that help will direct you to where you can pick out shimming from your system. Now, the importance of shimming is to make the cardiac imaging, that's the heart region, homogeneous images you are getting. It will exclude any artifact that comes from every other part of the chest, and just focus it on the card. And then every image you get of the heart is going to be isotopic. Isotopic meaning they are going to be synchronized. There will be no a little bit of bright here, dark here, fair here, not fair here, and all those stuff. When I started scanning, I underrated the importance of shimming. And what I did is, just like this one, I will open my shimming to cover the whole chest. What I am basically telling the system at that point is everything on the chest, including the lungs and the heart, isotope everything for me. And the truth is, we are doing cardiac MRI. There's nothing, I'm not really paying too much attention on the lungs. I should have just reduced my shimming as small as possible to, the heart region, so that the images I am acquiring at the heart region at that point becomes isotropic. Get that at the back of your hand. Okay. Like I said earlier on, you have to do the axial dark blood and white blood just to help the radiologist get an overview of the heart. So one of the images you get when you scroll through the axial image you get is this. It gives you this kind of images. This my cursor here. The left ventricle, the left atrium, the right atrium, the right ventricle. You get these images, then you can use these images to plan for your two chamber, plan for your four chamber, plan for your short axis, and then the three chamber, the left ventricular flow, and so on and so forth. These are very simple sequence that you can see in every system you're going to be assessing to run your MRI scan. Now, the two chamber localizer, you should learn how to plan them. Once you just click on two chamber localizer on your MRI system, the images comes out this way. Then you have a single line. You can increase this slice to maybe 2 or 3, depending on you. But because you are planning the localizer, you just need one image. What you are telling the system is because it's a single line, a single slice, you're going to be having just one image. If you increase this slice to 2 or 3, then you can scroll through this image to have another section of this. It might be in end diastolic or end systolic. You get other sections of this imaging. Now for the two chamber, just one slide. and it has to be parallel to the left ventricular septum. This is the left ventricular septum here. The slice should be parallel to it. And like we learned, I'm not a good mathematics student, but either way, one thing we learned during mathematics is parallel line does not meet. I don't know if I'm right, mathematics student. Okay, so parallel line does not meet. So you plan parallel to the left ventricular septum through the mitral valve. In between the left atrium and left ventricle, you have the mitral valve. So the slice is going to cut through it at the long axis. So you're going to look at the axis whereby you have the longest point here and the longest point here and cut through. So when you run this scan, which is going to take about 6 seconds, 7 seconds, ask the patient to breathe in, breathe out, hold your breath. At that point of holding the breath, that is when you're going to run this scan. You'll get this image here. See my green stuff here. This is the image you're going to get. So this becomes your localizer for the two chamber. So when you want to plan your Cine, all you just need to do is to come back to this two chamber and copy image slices or image position and put it there, and you go your way. You are done with this two chamber. When I started scanning also, I quickly, once I'm done with my two chamber localizer, I quickly want to go and scan my four chamber. And then I did a little bit of reading again. I realized that one of the experience I had when I started scanning is I tend to repeat my first chamber because I have to get the hearts, the four chambers of the heart in left ventricle, left atrium. I have to get the first chamber very clearly. I tend to repeat it a lot because I didn't know that there are other methods I could use too. So instead of going ahead after my two chambers to plan my four chamber, I will do a base, I call it a base short axis localizer. So what I'm going to do, instead of opening the full length of the short axis on the fourth chamber, I will only open to cover this basal area where I will get something like this mid. From the base to the mid, just here. Oh God, sorry. Just from the base here to the mid here, so that I could get a short axis image where I could easily see the left ventricle here and the right ventricle. This is the right ventricle, this is the left ventricle, and then these are the septums that divide the two ventricles. When I do this, I could then use my short axis here to plan for my four chambers to give me something like this. Now, when I click on my four chamber, I will need to bring out my two chamber localizer, which is this, and bring out my short axis, which is this. The systems are programmed in such a way that as soon as you click on each sequence, it will give you an idea on the way you are going to plan. All you just need to do is to position the planning plane very well. So what you do is to get the four chamber of this nature, you are going to cut across the perpendicular, the left ventricle and the right ventricle on the longest plane. On the longest plane, look at this here, on the longest plane, cut across. Then you adjust your plane on the two chamber to make sure it also cuts on the longest plane. But there's a little mistake we make when I also, sorry, I have to give you most of my experience. Some of the little mistake I made during those times is I forget to scroll through my short axis. And I realized that while I am planning on the short axis and the two chamber, my plane is cutting through the aorta also. So when I get my image, I see a little bit of connection here. And it looks like a lesion. When I send this image to the radiologist becomes confused. And they'll be like, what's happening here? I'm supposed to see the left ventricle, the left atrium and left ventricle clearly, without any connection, except I'm thinking of tetralogy or pilot, which it is not. So what I also now learned to do recently is to, while I'm planning on these two planes, I will bring out this short axis base and make sure I remove my plane to only cut these two, the left ventricle and the right ventricle. And then I make sure it doesn't cut through this aorta here. And then I get a good image. Are we with me? Any questions so far? Any question? Guys, can you hear me?
Yeah, we can hear you.
Here.
Okay, good. Any
We are
question?
waiting, sir.
Any question?
We are focusing on your experiences.
I know there are some
Yes,
of us.
sir.
Okay, don't worry. If you have been scanning MRI before, this might not really sound strange. So everything I've been saying might not really sound
I
strange.
have a question, sir.
Okay, just give me a moment. I know. Okay, what do you want to ask? Go ahead. Let me take your question.
I wanted to ask,
Yeah.
you said you can start with the axial dark blood. So I want to know, is it possible that after the axial dark blood, you can scan the white blood immediately before you
Yeah,
start all this?
yeah. There's something, and that's the white blood takes a longer time. It has a longer relaxation time than the dark blood. If you scan immediately the white blood, you are not wrong. You are very correct. But the idea is, patients are oxygen sensitive in the MRI system, and you don't want to stress them too much at the beginning of the scan, because those are the point that you want to get the best imaging. You understand? When you keep them too long during the white blood, after you scan your dark blood, that takes some few seconds, you then begin to see them pant for air. So what I do basically, it's not a general rule, it's just scan dependent to me. I delay my white blood till getting to the end of my scanning before the injection of contrast, and then I run it. At that point, I've gotten the basic images that my radiologist needs to give them the best. But also, I have also come to learn that not all cardiologists or radiologists want the white blood. With the dark blood and the basic BSSFP images, they are okay. They can run their scan and so on and so forth. So it's the white blood is center dependent. Some centers don't really do it fast. As I started practicing in this other part of the world, I realized that they don't even do white blood. They tell me it is a KEP. I don't know why, but maybe I'll read more about it. Do you understand? So you are correct. Either ways, any way you want to go through it, you are correct.
Thank you, sir.
Good, perfect.
Yeah.
So now, what I don't do also during my early days of scanning is the 3-chamber localizer. I tend to go and get it when I've done my sign for 2-chamber, 4-chamber, and short axis. But common knowledge demands that I should do it so that I don't really stress myself during the scan. It's not a rule of thought, but it's something that to make your work very easy. To plan for the 3-chamber localizer, you bring out your 4-chamber this way, and then you bring out your base short axis. Now, when you are scrolling through, because your short axis base is stack of images, it's just about 10 or 12, 16 images. When you are scrolling through, you are looking for what they call the snowman eyes. Most of you who have watched the movie Frozen, I don't know the name of this guy that played a major role in Frozen. You see, he has 2 balls, one up, one down. When you invert it in the lateral sequence, you are looking for the snowman sign. They call him snowman. You are looking for, so you imagine the upper ball here is this, and the lower ball here is this. So you are looking for this sign, which is the left atrium, left ventricle. And then what you do, you cut across it perpendicularly. And then when you are cutting across it this way, you are also trying to make sure you keep your planning plane the same way on the 4-chamber. And then what you have is this. So you have why they call it the 3-chamber. You have the aortic outflow here. You have the left atrium here. And then you have the left ventricle here. That's for that. So after you have gotten all your localizer, the next point is your BSSFP images. I'll tell you, there's, I think a year or 2 years ago, I posted something on LinkedIn. I was thinking BSSFP images are very beautiful, and I like my 4 chambers. I like my 2 chambers. I posted it on LinkedIn, and then, people were commenting, but a lady made a comment, and she was like, I love the BSSFP image. Before then, I don't even know what BSSFP is. So I had to go back to my little shell and go and read up BSSFP, and I realized that my sign images that we get during cardiac MRI are basically BSSFP images. They are just I call them the beautiful image. So you have to plan for your 2 chambers, a 2-chamber sign, 4-chamber sign, 3-chamber sign, and so on. So you don't need to go through the planning sequence again. All you need to do is open up the sign 2-chamber, go to your localizer for sign to chamber and copy and paste. You will get this image here. This is basically the left ventricle, left atrium, the head of the aorta. All you just need to do here is to adjust the field of view. Basically, during cardiac imaging, we use large field of view. Why do we use large field of view? Because just like in radiography, larger field of view gives a better spatial resolution. You understand? It gives a better spatial resolution. You also need to capture your cycle. Don't worry, every system comes with what they call capture cycle. It's just basically telling the system that, okay, I'm ready to scan and I'm ready to pick the heart rate during the end systolic or end diastolic, depending on what you want to scan with. But like I recommend during this lecture, you should go with your hands and end systolic. The fourth chamber also, the same thing. Go to your fourth chamber, copy the image, because before you take the patient in, you had explained to the patient not to move their position, because at every point when you get your localizer, the system assumes that the patient is still at that point. So the system just go back and copy what you have done initially and post it on the fourth chamber and sign. And then what you have is this, but beautiful image, not what I have here on my screen. Don't mind my image. That's for that. Or like I said, also all you just need to do is to adjust the field of view, copy, capture cycle, and small shimming. Small shimming. I cannot emphasize this more. For the fourth chamber, you could just limit your shimming. See my hand this way to the left ventricle alone. You can. Or you limit the shimming to this part of both the left ventricle and the right ventricle alone. You don't need to open to other part of the chest. You can even limit to the heart alone, just that heart section. Do not go beyond that, because the smaller the shimming, the better. Okay, the sign short axis, the same thing happens now, but in this case, you have to open from the base of the heart to the apex. And if there are indications of pericardiac fluid around the apex of the heart, you should also try to cover the fluid. Or if you know a lesion extending extracardiac, you should also try as much as possible to open your slice to capture the lesion. So all you just need to do is to go copy your short axis localizer, open up the slice from the base to the apex, which is from here to here. Small shimming, adjust field of view. Some systems comes with free breathing for short axis. And then some other systems, you have to be the one to give the patient breathing instruction. Either ways, you are still correct. Okay. If you have done your 2-chamber, 4-chamber short axis, I call them the basic X-ray view. Then you can then think of, after you have had discussion with your cardiologist, what other views do you want? You cannot run away from the 3-chamber, which is this. Remember, all you just need to do is to go and copy and paste, you get this. And then you have to also think of the LVOT, left ventricular outflow tract. You plan parallel to the aorta. Parallel, not the left atrium. This is the left atrium here. You are not planning this way. You plan parallel to the aorta. How do you know? When you plant parallel to the aorta, you have this image here. So you see left ventricular outflow tract here. It's basically simple. Don't mind the way I put it on my system and makes it look a little bit difficult. It's basically simple. Okay. Sign right ventricle. These are not statutory imaging. Like I said, also is dependent on what your cardiologist wants. So it is what your cardiologist wants that you're going to give to them. So this is for the right ventricle. Like I told you on the sign short axis base, you have the left ventricle, right ventricle. So while you cut through this one to get the 2-chamber left ventricle, you also can cut through the, right ventricle perpendicularly, and then you have here, which is going to give you the side right ventricular and the right ventricular outflow tract, and so on and so forth. Okay, there's something that I need to bring to attention. Maybe you guys that have been scanning can try this on your system. I didn't have time to try it while I was in Nigeria, but you can help me try this one when you are in your system. If you want to plan the full length of the aorta, you are just giving your radiologist additional, and like I also said, cardiac MRI is indication dependent. You should know how to plan your sequence based on the indication the doctor is trying to rule out. For the ascending aorta, scroll through your axial dark blood to where you have the ascending aorta and the descending aorta. You know, if you go up towards the apex of the lung, you're going to see these two are connected by the arc of the aorta. So plan across these two here. Plan across these two here, the descending aorta, just perpendicular to the two of them, and let this line run through the arc of the aorta. If you do this, what you will get is this here. You will get the full length of the. I have not tried it personally. It's something I learned recently. So I want you to go back to your system, and help me do this and give me feedback within the week if you attend to any patient for cardiac. Your feedback will be highly, highly, highly appreciated. Now, okay, so we are done with all the basic scan and all those little scan. Let me ask us a question. Have we seen this imaging before? I don't want to call it the name. This, I know you have seen this. Have you seen this? Okay, are we together? I want to get feedback from you guys. Are we together? Are we seeing this before?
Yes, sir.
So
no, we've not seen it.
What is it called?
I think it's
What
an
is it?
artifact.
Sir?
I've not seen this type before, but my guess would be an artifact.
Okay, you are getting there. That's fine. That's fine. Any other person?
T1 mapping.
T1 mapping. Wonderful. Okay. Artifact T1 mapping. Please bring it on. Any other one?
It's like a grid cardiac MRI.
Grid cardiac MRI. Okay, that's Wally. Okay. One more. Then I'll know what to say. I don't want to. In the next 5 minutes, I want to be done. One more person. My guys from Southeast Asia, my guys from my African guys and South America, give me an idea. You guys are more learned than we in Africa. Okay, guys. Let me know. I think I see some messages in the group. Tagging. Okay. So this is basically for tagging. So 1 second. Okay, good. So though it is not really used now in low and middle income countries, but one thing that radiologists, cardiologists now use in assessing the heart function is what they call tagging. And some of you really got it. Tagging is basically you putting some grid line on the long axis or the short axis, and then use it to assess the what do they call it? Contractility dysfunction of the hearts. Now, I had to ask a cardiologist, I can run this. It's just a basic sequence on the MRI system where you just need to copy either your fourth chamber or your short axis mid and run it. It will give you something like this. Nothing really much about it. But what is the important when it comes to cardiac imaging for radiographers? Now, the man explained to me that you see this line that runs through the septums. Follow the line through. It runs through even to the extracardiac area. Follows the line through to the extracardiac area. If the lines you see here are synchronous, that means the heart is still. The contractility of the heart is just very low. But if the lines are disjointed, that means it is pumping most effectively, very well. And then you realize that, there's good functioning levels of the heart. And for this one, this is just one of the sequence under portal vein. Don't mind the imaging, it just is a single sequence post-contrast imaging. And then for this one is just the basic assignment I gave you earlier, where you help me cut through perpendicularly across the arc of the aorta, ascending and descending. Or try this on your system and let me know what you. I'm not sure most of us have license for this. I'm not sure we have license for this, but I'm just bringing it to your notice on the importance in contractility dysfunction. This one also, I'm not sure most of us have access to this, but if you are in a position of authority and you can influence the system that is going to be supplied to your hospital, tell them to activate the grid line for you and activate the portal vein for you. This one, I think most of you have access to. Okay. TI Scout. Now, I will state something I should be done in the next 3 minutes. I'd like to state something to us. One of the mistakes I make is when I started scanning, I didn't really understand what TI Scout means and the importance. So I tend to just figure out anything and throw it to the cardiologist. And the cardiologist has been so gracious and just taking all my sheets. And because I'm so busy, I didn't really have the time to read about it. But at least for now, I will just give us the basic knowledge for TI Scout to help us. TI Scout is basically gotten after 10 minutes. Not 6 minutes, not 7 minutes. The minimum time is 10 minutes. The sequence you run for TI Scout is the mid-short axis. Mid-short axis. At this point, you have to really explain to the patient the importance of, 10 minutes post-contrast injection. Guys, 10 minutes post-contrast injection. At this point, you have to explain to the patient the importance of holding their breaths. Because it is very sensitive to breathing, and if you are not, how am I going to put it? If you are not, if the patient is not cooperative, it's going to affect the imaging you get. I don't know if you understand me. So explain to the patient the importance of breathing at this point to reduce artifacts. And then because you're going to be using this to plan for your short axis post contrast, which is the LG sequence, and then the three chamber view and so on and so forth. 10 minutes post contrast, mid short axis, explain to the patient the importance of holding their breath. Now, when you do the TI Scout, because you are trying to see the darkest point in the myocardium, you should try as much as possible to scroll through the image quickly and check through if there's any artifacts on the myocardiums, especially. What I mean is you have to look through the myocardium this way to be very sure that there is no artifacts. Look through the myocardium to be very sure that there's no artifact before you pick your TI number and put it into the short axis post LG sequence. What that means is if there's an artifact, especially most of the artifacts I read about comes at the inferior lateral aspect of the heart. If there's an artifact here, well, then I think I did something similar. I didn't. If there's an artifact here, if there's an artifact here, maybe some dark patches here, how then do you remove the artifact and bring it out of? There's something they call frequency shifts, or you adjust your field of view. Go to the help system on your machine and type frequency shifts and look for how to adjust. When you do that frequency shift, it can kind of help you shift the artifact that you see here out of the field of view. You can also adjust your direction, phase encoding direction to push the artifact out, or you can adjust the field of view to help you push the artifact out. Either way, if you have a very good TI Scout and you have a very good dark mid, and then you select the TI, when you run the scan, you can see areas of fibrosis in the scan. Look at these white patches here. These are areas of fibrosis in the scan. That helps the radiologist to see them. That helps. So if you have a very bad CI scout, and then you run the short axis post LG sequence, everything might just, everything might just appear too black or too white, coinciding with the flows within the heart. Also, you should also note that a good imaging highlights the myocardium and makes it a little bit dark. So if you run your sequence LG, late LG, and then your myocardiums are not dark, then there's something wrong somewhere. You have to figure out how to remove that artifact from your system, and so on and so forth. Okay, let's leave all this. I think I've explained that. I think when we start the image arting, we'll be taught about the BMOR, you understand? We'll be taught about the blood oxygen dependence level. What this does is, these are new techniques whereby you don't need to inject contrast into the heart. All you need to do is to assess oxygen intake within the myocardium of the heart. And these are just basic sequences. As long as you know how to do your short axis mid or the long axis two chamber, 4 chamber, these are just sequences you copy and paste. They are basically run under the short axis or the long axis 4 chamber. That's just, even the MOLI, which is the T1 mapping, are basically ran under the sequence of the short axis mid. Short axis mid, you get your MOLI and you go, but actually the suppliers or the vendor needs to give you access to this system before you can. But I will just be focusing on this, which is the oxygen sensitive cardiovascular magnetic resonance, which is a technique, not I said blah 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 and so on. Now, the difference here is, of course, we know that the short axis oxygen sensitive, how am I going to put it? The short axis oxygen sensitive imaging is basically when you ask the patient to take a deep breath in, deep breath out. You understand? I want to show you a video of the difference between the normal, because you can run this sequence. I'm going to stop sharing this. I'll come back to this temporarily. Okay, good. Can we see it now?
Yeah, we can.
Okay,
Yep.
good. So
Yes, we can.
look at the way this patient breathes. I'm going to use it to explain one or two things to us.
Breathe more deeply.
Can we hear the sound? Did you hear anything? Did you hear the sound? Did you see the patient breathing?
I just saw the movement, the rapid movement of the heart.
We had breathe properly.
I heard a breathing instruction.
Okay, good, fine. Now, the idea is this. The idea on this is, the leads are connected to the patient inside the MRI scanners. Now, it gets to that sequence where you have to, it's just like a sequence that runs for 4 minutes. The sequence basically runs for 4 minutes, which is short axis mid, 4 minutes. The slice thickness is about between 8 and 10 millimeter, which is basically the adjustment you have to make. The first 1 minute of the 4 minutes of this sequence, the patient breathes normally. Just like a normal breathing sequence, the patient just breathes normally without metronome, just normal breathing without no issues. Tell the patient to have their time breathing. The next 2 minutes of the sequence, the patient breathes with deep inspiration, deep expiration, deep inspiration, deep expiration. Let me play another video for you. Oh, let me close this. Tell me if you can see this. Can you see this?
Yes.
Can you hear any noise?
Not a lot, no.
No.
But can you see this image on the screen?
Yes.
Yes.
Yeah, we can see
You
it.
can see this image. Now, the idea is I have to do this video myself. When I play this now, take note of this stuff, because this is the ECG reading on the system. You could see that the patient is taking a deep breath in, taking a deep breath out. For 2 minutes, the patient will do this. That is what they call the hyperventilation. So you are assessing the myocardium when the patient is loading him or herself with a lot of oxygen. You run the sequence, and that is when you now send the same sequence to the radiologist, and then the radiologist can run an analysis with an analysis software and then get a good, let me play it again so that you see. So follow my, you see, breathe in, breathe out.
This is a normal breathing. Okay.
No, this is not the normal breathing. You can see these are the normal breathing here, but these are the hyper breathing. Seeing it going, you know, these are the normal breathing, but look at this one going above. You understand?
Yeah.
So
yes.
So the first minute the patient breathes normally. The next 2 minutes the patient goes on hyperventilation, and then the last minute, which makes it 4 minutes, the patient basically is going to hold their breath for breathe in, breathe out, and then the patient will hold their breath for at least 40 seconds. At least 40 seconds. Now, that 40 seconds, we need to then understand that, oh, this is how long the patient can hold their breath. And then we can assess the images from normal breathing to, you know, hyperventilation breathing to, you know, free non-breathing stage. You send this image, you run a motion correction on the image and then send it to the radiologist. The job is done as the radiologist. Then they are going to run an analysis on this image and then be able to tell the oxygen-dependent content of this system. The best thing is this. For the normal perfusion imaging, you can only assess very well the left ventricular flow, the left ventricle issue. But with this hyperventilation, you can not only assess the left ventricle, you can also assess the right ventricle and the global view of the heart effectively to know how much tissues in the ventricular or the arterial area of the heart are accepting oxygen and are giving out oxygen. Okay, I think I have done quite a number.
Please, I have a question.
I have a question.
So,
please do.
Okay.
But don't kill me with question, please. Good, let's go.
Okay, so my name is George. Okay, so the oxygen what you just described, is it a software, a new software that needs to be installed on the machines or most machines?
Yeah, that is what we are trying to fight out. That is why this training is here. Is a new software that are being used, because one thing you can agree with me that there's a shortage of contrast globally, both for CT contrast and MRI contrast. So scientists are now coming together to assess. I don't know. Can you see my screen? I want to go back to my slides. I think I'm done. I am just going to take your.
No.
So, guys, you're going to go. Zoom. Good. Okay. So these are basically, because there are shortage of contrast world over, scientists are now coming together to make sure to design protocols that you don't really need contrast. So instead of perfusion imaging as we know it to be using contrast, we now do oxygen sensitive imaging. Oxygen, you're just going to assess the oxygen intake in the cardiac muscles. It's a new sequence and it's very simple. You don't need to disturb yourself. You just one sequence alone, run this hyperventilation phase included in your T1 mapping, T2 mapping. You are good to go. You get a good analysis of the heart tissue. It's a new sequence that they are now implementing in the West, and they are looking at implementing in African or Southeast Asian and American countries.
Oh, okay.
Yeah.
Okay.
Okay,
all
good.
Right.
I can hear you. Yeah.
Yes. So my name is Norbert. I'm from Ghana.
Okay.
So back to the oxygen dependence protocol.
Mm.
So as part of this 4 minute protocol, mention that the final part is a 40-second breath hold
yes.
sequence.
Yeah, perfect.
I would like to find out if there is an alternative to that. The truth of the fact is, even if I do abdomen and pelvis sequences, breath hold sequence, even for 15 seconds, it's quite difficult for patients to hold their breath for 15 seconds. Is there any other way we can go around this?
So can I let me be, because I asked this same question when I was being trained. I'll be very fair with you. There is no two ways about it.
Wow.
Hyperventilation is hyperventilation. You cannot run away from it. So you have to explain to the patients. Explain, that is where that explanation. Madam, tell them the implication. If you can't hold your breath, master, you are out of my scanner. You can't do anything for you for now. Except maybe in the future, then they can adjust the sequence to say, okay, the patient can breathe and breathe, blah, blah. But at least the patient can hold their breath for 40 minutes. We have attended to aged patients who find it difficult to hold their breath. We have to explain, but this is the, and if patient cannot hold their breath, you can't kill them. Boom, you're out of my scanner. I have another patient waiting. Let's move on. Are we good?
Yes, we're good. Thank you very much.
Yeah.
Perfect. Okay. I don't have time again. I wanted to explain this to us.
Please go ahead. Please go ahead.
Okay, good. Okay, so let me just conclude with this, because when you are planning for your hyperventilation sequence, basically this is the planning. You will see here, that is where you have the mitral valve connecting the left ventricle and the right ventricle. You don't plan across the mitral valve because the valves are always opening, flipping. And that flipping causes, motion. This sequence is motion sensitive. So what you do is plan below the valve. Below the valve. So if your mid short axis you did for your normal sign short axis you did earlier is here, which you are very correct. But when you come to the hyperventilation sequence, this is what you get. You have to put it away from the mitral valve here, so that while this valve is opening and closing, causing motion, it wouldn't really affect your acquisition parameters here. Okay, I've explained this to us. Oh, can you hear anything?
Yes.
You can hear, right?
Yeah.
Now, see, when the patient is holding their breath, this is what you have.
Yeah.
Just clear. And then when you're also doing your normal imaging, breathe in, breathe out, patient hold your breath after breathing out, this is what you should have. There should be no spiking. Clear. For the few seconds you are going to run that sequence and so on and so forth. This one breathes with the beep, pum, pum. See how it's going? You see how it's going? So that is the hyperventilation sequence. This one is the free breathing. The heart just breathes normal. No going up, no coming down. Then this very last one is the breathe out, hold your breath. You see the thing going just clear without any. So the patient has to be able to hold their breath for 40 seconds at least. If the patient does up to 50 seconds, fine and good. It gives the radiologist more time to plan their, So I've taken my time to explain these stuff to you. Careful explanation to patients. That's for the OSCMR, baseline measurement of Ruler 35. This is your T1 scan. Prepare breath hold sequence, gentle breathing instruction while scanning 120 seconds, hyperventilation 60 seconds, and breath hold 40 to 60. These slides will be made available to us by the camera team, so never mind. And then most importantly, my conclusion. Cardiac MRI is still evolving. We are looking at strengthening the gains that have been made all over the world in Africa, and that is why I am here, that is why you are here. I pray with this little prompt of mine, I've been able to convince you and not confuse you that cardiac MRI is simple and it's something lovely to do. I want to see a lot of guys just specializing in cardiac MRI and just wowing everybody out there. Thank you.
Thank you, Harry.
Yeah. Okay, Marina, up to you. I think I'm done. If there's any question, we'll be glad to answer.
Yes. Well, thank you for the presentation, and also if there's any questions about SWiM in general, feel free to ask them. Otherwise, I think we're skipping the networking session today because of the delayed start. Sorry again for that. And yeah, any questions?
If there's no question, or maybe during the next tutorial class, and when they have their time together, they can just drop it in our next tutorial class, and then we know. We have kept them really waiting today, and I really appreciate their patience.
Yes. Yeah, we encourage you to meet with your teams at least once per week, even if it's just to go over what you have done in that week.
Okay. One
yes.
second. Somebody asked a question. Nomi asked, she had a question to ask about the snowball. Nomi, can you speak? Let me quickly take you before we go.
Yes, I can speak it. You were showing us on the snowball. If you can go back onto that slide for me, because I was mistaking it with on the other side, but I think you showed on the upper side of the snowball where you
good, fine.
you demonstrating with such.
So this is it. Well, okay, you want me to explain it a little bit again?
Yes.
Okay, good.
So the snowball is the one that has the yellow line through it. That's
exactly
where you see
this is snowball. This is first edge here.
Okay.
Second edge here. Then you run perpendicularly your scan line through it.
Okay.
You understand? So when you run perpendicularly your scan line through it, you should also learn to reposition your line on the fourth chamber to make it perpendicular on this also, and then you get this.
Okay.
So why I brought out this one is just to show that this year, it looks like this beautiful man here, and we're good. You understand? Thank you. Yeah.
Thank you.
Okay. Thank you. If there's no Marina, I think I'm done. Thank you.
Thank you. Okay, so the recording of the tutorial will be uploaded on 4Waves as well. So for anyone that couldn't attend, or if there was something that you missed, then you can go over it. And yes, otherwise we'll see you on Tuesday for the first presentation of the Imageathon. Okay.
Hi, Marina.
Oh, yes?
Good. I think yesterday we were supposed to have a Philips demonstration, and when we tuned it was more of a, I think, was it French or Spanish? French. It wasn't French.
Yes, there was a
French.
There was a French Philips demonstrations, but this was only the first one. The remaining ones will be in English because we realized that there's not enough French speakers for it to make sense to have it in French. So from now on, it will be in English.
So would there be a repeat of the one they did, or to be a continuation?
So
repeat and continuation.
Mr. Serai will go over will summarize the first one in the second one briefly, so that you have some of that content in English. It will just be a summary, but at least that.
Okay, thank you.
Okay. Any other questions? Then I will.
I want to say that thank you for last week. I proposed you guys put in on demand the previous weeks, and I think you've done that, and I appreciate it. And it's been very helpful.
Yeah.
Thank you.
Thank you. Anyways, if you have feedback, please let us know. Then hopefully we can incorporate it. Thanks. Then I will stop sharing now. Stop recording, and then this will be available for you later.
Thank you, guys. Have a wonderful day.
Yes.
Thank you, Harry. Thank you,
yeah,
Manda.
Thank you.
Bye.
Thank you.